at Doctors of the World, we run clinical services in the UK and provide advocacy support, and we'll support anybody who's unable to access NHS services. The main thing that our patients have in common is a migration history. 95% of people were not born in the UK. And then alongside that, insecure or no immigration status is the next most common factor amongst our patients. And so it's through providing these services that we get a fairly good picture of the types of challenges and barriers that people face accessing NHS care. And now, with all of our patients, our end objective is to get them integrated into the NHS. So during the pandemic, the evidence was really, really clear. It couldn't be more stark that migrants had worse health outcomes. They had higher rates of hospitalisation. They were 35% more likely to be hospitalised with COVID and with a severe COVID infection. They died from COVID infection at higher rates as well. Excess deaths amongst people who had been born outside of the UK were 3.5 times higher across the board. And then there was even higher rates of excess deaths within certain groups. So, for example, people who were born in Central or West Africa, they had 4.5 times higher excess death than the UK-born population. And there were also much lower rates of vaccination. It took 4 months longer for migrants, people born outside of the UK, to get to 75% coverage for the first vaccine. So there's a substantial time delay as well. And the reasons for all of this was, first of all, that migrants on the whole had increased exposure to the virus and they were less able to protect themselves, which I think certainly has come up in the report. Secondly, they had limited access to vital tools in protecting themselves. They had limited access to testing. There was no restriction on access to testing, but because of bureaucratic reasons often related to being registered with the GP and also actually having a financial footprint in the UK in the case of testing, it was very difficult for migrants to access testing, and similarly with the vaccine. Migrants are fully entitled to access the vaccine, but bureaucratic barriers made it extremely difficult, and that's one of the key factors why we saw this delay in vaccine levels. And then the final issue is that in law, not all migrants, it depends on immigration status, but a proportion of the migrant population have restricted entitlement to NHS services. So it means they're not legally entitled to access for free certain NHS services. To give the COVID example of it, even though COVID treatment was exempt from all charge, regardless of your immigration status, this didn't cover conditions or complications which arise from COVID-19 infection, including long COVID, and it didn't cover any coexisting conditions. One of the reasons why this is a very narrow exemption, but one of the reasons why this exemption was so problematic and difficult to apply in the case of COVID is that it became very clear early on in the pandemic that severe COVID infection was highly linked to pre-existing conditions. So by default, the people who are most likely to become severely unwell with COVID, to be hospitalised and to then come up against this sort of entitlement to free services issue were exactly these kind of complicated cases, people who are likely to have complications from pre-existing conditions or people who developed complications, which also wasn't covered. And then also, of course, the long COVID issue as well. That was a huge omission in the exemption. And we know this from before the pandemic, and it continues to be the case now, which is the restrictions on NHS care, the NHS charging policy, as we called it. The impact of it goes much, much further than people who are technically not entitled to secondary care services because of their NHS status. It deters a much broader group of people who have concerns about their immigration status from going anywhere near NHS services. So that was, we had this really problematic, difficult to apply technical exemption during the pandemic, but it was really, even for clinicians, very difficult to apply. But the sort of like real life impact of that, it was applied to a population that has known for years and years that the NHS is not a safe place for them to go. They run the risk of having huge bills applied if they receive treatment, and it also comes with the risks of being reported to the Home Office as well. So it's deterrence is the main issue. It's not even the sort of like charging issue in hospitals. And throughout the pandemic, the government, we continually raise this as an issue, and not just for the migrant population in the UK, but as a vaccination and infection control issue as well. It mattered to everybody that people got treatment and that people were able to control infections and that people got vaccinated. And the government consistently ignored and refused to properly look at this issue. And I'm going to, as part of the COVID inquiry, Kemi Badenoch gave evidence, and I'm just going to, I think sort of like her response to this issue is sort of like worth, I'm coming towards the end of my time, but it's worth sort of like taking a minute to hear. When she was asked about this, she said, and you know, I couldn't have put this better myself, she said, undocumented migrants' interaction with the state will be minimal to none because they will be worried about being reported, being deported, and that's just a fact. We cannot adjust our health system to undermine borders and border security. That will create loads of other problems. This is just something that I think we need to accept. And there was a government's official line was slightly different, but I think, you know, we got insight there with Kemi Badenoch saying actually the quiet bit out loud, that was government's approach all the way. They were very relaxed about this idea of migrants not being able, certain migrants not being able to access NHS services and not being vaccinated. I mean, this doesn't really need to be said, but I think it's important to say that a particularly unjust and egregious dimension to the policy is migrants who are the target of the policy also make up a substantial part of the health and social care workforce. So it creates this situation where, and particularly during the pandemic, people who are highly at risk of being exposed to the virus, who are spending their time providing care, saving lives, their families and the communities that they came from often did not have equal access to the protection and treatment that the rest of the population had. And a sort of really telling and example of this was the performative spectacle that was the first delivered vaccine in the UK that was delivered to a 91-year-old lady. It was delivered by a nurse called May Parsons, who had worked in the NHS for 24 years. May Parsons is the Filipino nurse. And at the same, as this was happening, at the same as we had this very heavily covered media event that we're very proud of, and rightly very proud of, the Filipino community, not just the Filipino community, the Filipino health worker community was dying from COVID at a disproportionate rate. It makes up just over 3% of the NHS workforce, but in May 2020, 22% of COVID deaths amongst nurses were Filipino or Filipino nationality. And another sort of like, so it's an example, we know it's a population that it has various different types of immigration status, and at Doctors of the World, year on year for the past 10 years, every year the most common nationality accessing our services is Filipino. So it's a really stark example of a migrant population within the UK that's so heavily integrated into the health and social care system, but simultaneously has extremely poor access to medical care when they need it. The final point I was going to make, and I'll make it very quickly now because I'm over time, is a point about NHS charging and privatisation, and maybe sort of like linking up to some of the things that that John said. I think it's often been said, and you alluded to it this earlier, which is that privatisation within the NHS will be by stealth. Like, you know, we even see now that it's sort of one of the few things at the moment Keir Starmer will criticise, and is trying to put distance between himself and Nigel Farage. He keeps, you know, loves to reiterate that Nigel Farage wants to privatise the NHS. So, yeah, we know it's not going to be politically acceptable in this country to outwardly say it. But I would, the NHS charging policy that applies charges to migrants, it was a departure from the founding principle of the NHS that would be based on need rather than ability to pay. But I would also propose that it is a really concerning part of this privatisation by stealth, and it's a departure from the provision of care coming from general taxation. It's coming from direct charges from patients. And sometimes it's been said before that there is a policy document for the NHS about how to apply the migrant charges, which is about 100 pages, it's over 100 pages long. And it's been developed over time, but it is also a manual of how to charge anybody for NHS care. It's sort of said you can take the front page, take the word migrant off the front page, and you've got a manual of how to charge anybody. And I think this is a real concern, and it's not just scaremongering. The NHS has spent over 10 years now refining and getting much, much better at charging patients for their care. At the moment, just migrant patients. But it's got much, much better at doing it. NHS Improvement has spent a number of years improving the efficiency of NHS trusts doing this. There are teams across every NHS trust in England now that work applying charges. There are card machines in every NHS trust, so the infrastructure is there to take money from patients. And possibly more concerningly, NHS staff are becoming exposed to the idea and becoming accustomed to the idea of withholding medical care when people can't pay. NHS management and NHS lawyers are having to becoming accustomed to defending decisions to withhold care, and also a body of case law is being developed on the circumstances in which it is lawful to withhold care from people who can't pay. And then also as well, it's partially being delivered by private companies. But yeah, so that was, I guess, the sort of like final point that I wanted to raise. When charges were introduced for migrants, it was unjust, it's unethical, it's inhumane, they're often applied unlawfully, and we should have stood in solidarity with migrants when their healthcare rights were eroded. But we also should be really aware of the very clear and obvious risk this presents and how difficult it will be now that the infrastructure is in place to resist direct patient charges when government decides it wants to increase the pool of people that it wants to charge.